people in the lunch hall. And welcome to some late arrivals. You're welcome. Nice to see you. So let's start on time because we absolutely have to finish on time. We have some of our speakers who need to leave at 3, and we've got a lot that we want to discuss. I don't think I need to set the scene too much. The morning and the discussions around UHC, NHI, equity, complex intervention design, I think it's all kind of threading through the morning already. Yeah, I guess importantly, the kind of the values-driven work that we do, not forgetting that why we're doing what we're doing. So this afternoon's panel brings a range of voices. I think you would have seen the program and where people are coming from. And we're trying to bring in those different views, but also through the discussion, hopefully find some common threads. So I'm very happy to have Yanga here, my co-moderator. And what we'd like to do is we'll have the first 3 speakers speak in a row. We'll introduce each and as they come up and allow them to speak. And then after 3 talks, we will just open up for questions. So I'm asking my panel members also to keep their curiosity hats on and the audience so that if you have questions, we'd particularly like to hear voices, younger voices, emerging voices, different views, because that keeps us on our toes. And then we'll hear the next 3 speakers and have a moderated conversation between the panel and with each other to discuss this exact topic. What are the challenges to achieving UHC in an unequal society, and what can we do now? So I will hand over to Yanga.
Thank you, colleagues. Gosh, I'm so short. It is so wonderful to be here. I have the pleasure of introducing the first speaker for this afternoon session. And it is none other than Professor Nicholas Crisp, who is a medical doctor by training, but also a public health scientist, who's an honorary professor in public health medicine at the University of Pretoria, who has years of experience working in government at different levels, and who is now the Deputy Director General in the National Health Insurance stream of the National Department of Health. Thank you so much. Over to you.
Okay, thanks very much. Good afternoon, everyone. This is the postprandial hour. If I catch you sleeping, you're in trouble. Yeah, so just watch out. We are watching. I've got other monitors over here. Yeah, thanks very much for inviting me to be part of this. And it was interesting this morning hearing about how we all invent our own terms about universal health coverage and NHI and what. And so when I saw who else was on the panel, I thought, let me just stick to what I actually do at the moment and not get sidetracked to all the other things that I enjoy. So I was asked 4 questions, and I'm going to just give some thoughts about those 4 questions. One is, what's the most pressing challenges, or the top 3, for progressing to UHC? Well, there are hundreds, so I've got to just pick 3. And I said, one of the big challenges that we are facing, where I sit at the moment, is that financing the current health system is unbelievably complex. Many of us work in the public sector, and that's complex enough with the 9 provinces and the national department. But there's 71 medical schemes with 311 options, 833 trustees, and all of that private financing to look after 14% of the population, 9 million people, costs 9% before you give 1 tablet to a patient or touch a patient. 21 billion rand a year down the tubes. And that same administration admits to 28 billion rands worth of fraud per year. So the first issue is there's a bucket load of money out there that has just been poured into a big hole. Second one is that users and providers have learned to game the system. And we have to reteach the public, both the members of the public who use the health system, and we use the term users because otherwise we get in trouble with Sue for not talking about promotion and other things. We're not talking about patients now, talking about users of the health system. They've learned to cheat They've learned to manipulate the system, add codes, use other people's cards, use the public system and the private system interchangeably, use RWAPs, use this, use that, to waste more money. That's the second pressing problem. The third one is that our entire health system has evolved to look after sick people, not to maintain health. And that's exactly what it shouldn't be. In fact, looking after sick people should be seen as an admission of failure. So what we should be doing is we should be looking after the full spectrum. And we heard it from Mosa this morning, taking from prevention and promotion right the way through until we get to rehabilitation and palliation, and we eventually depart this mortal coil. So for me, those are three massive challenges because they're mind shifts, massive mind shifts on how we're going to tackle the future of our health system. The second question I was asked is, what's the potential system-wide interventions or reforms within and outside of the health sector that could be tried and scaled up? So the key here for me is scaled up. Every day I get an email or two or three from someone who wants to come and sell me a package or sell me a solution or sell me some private system model of my IPA and my this and my that. None of them are scalable. We have to look after 62 million people. The question is, how do you put systemic change in place? Well, the National Health Act, and that's what I tried to say this morning, don't read one piece of legislation to get the mandate. You have to read lots of different sources of where the mandate in the state comes from. It already makes health the responsibility of the minister, the MECs, and all of those of us who work in the public sector in particular. And that means the whole value chain, including the responsibility for what we can in the social determinants of health. Doesn't mean we need to go and fix the water system, but we do need to advocate for it. So that is something that is quick and easy. We need to get into forums and places where we can influence others who can definitely intervene. The second one is that we could very quickly fix prices in the private sector. Now, that was stopped by the Competition Commission and the courts back in 2009, but we are now a lot wiser than we were then, and we know how to deal with this. We need to determine the prices in the private sector. We cannot have people with a runaway train just charging anything they want and adding codes. The third thing is that we need to start paying, and this is part of what the NHI is aiming to achieve, we need to start paying for healthcare in a different way that removes the perverse incentives. So in primary healthcare, that means capitation. Now, there are plenty of risks. Those of you who understand how capitation works, there are plenty of risks of over and under servicing. So the way we design it, and I don't have time to go in for it now, but one thing we know for sure, fee for service must go. Does it sound familiar? Free for all, free for service must go. Okay, so we need a movement of fee for service must go. The third question I was asked was how best to advance the evidence-based and or evidence-informed policy process. We talk very easily, those of us who work in the health sector and in research institutions, universities and so on, about evidence base. But using the evidence base to actually do what we're doing. So we try in the public sector. We have standard treatment guidelines. We are now starting to do more health technology assessment. We're linking with other authorities that do it. But what I've seen is that once you're in the private sector, there's no standards. There's nothing. You do what you think, and it's the good old boys who make the decisions. We have to make sure that as many people as possible have access to the depersonalized data so that you can see the evidence yourself. You don't need some government telling you. You need to be able to see that this patient, this person, this individual who lives in a home, in a community, in a family, that keeps coming back into the practice for some or other healthcare has got some other problem out there. Sometimes they're hiding those other problems, and you've got to deal with a holistic person. We need to focus on outcomes, not outputs, because that's what we count. Even in the public sector, we report on outputs. There are a few outcomes, like infant mortality rates coming down, survival is going up, average mortality is improving, and so on. But the actual outcomes of what we do, are we reducing hypertension generally in a community? Are we getting on top of diabetes because of our promotion and our better diets and working with education authorities and everything else that we should be doing? And I think there's quite a lot of opportunity to not be counting widgets and to be reporting and working towards outcomes. When we plan research, and now that's specifically looking for this forum today, because that's, I guess, the question that was asked is how does the SAMRC and those that it associates with help us in the department, and me in particular with what I'm responsible for on NHI, to get the evidence? Well, there's every aspect of what we're doing needs evidence, and we need research, economic, patient care, choice of technologies, the whole HTA process, choice of the programs that are included, which benefits we put in first, how do we scale up? All of those needs us to have evidence. And so I think having some kind of empirical research being done that is global would make a big difference. The fourth question I was asked, what's the potential strengths we need to build on to advance UHC? So I firmly believe, and actually Mosa said it this morning as well, is that the primary healthcare platform in the public sector in this country is fantastic. I've worked in 7 countries in Africa. It's fantastic in this country. We do not give ourselves enough credit for the amount of effort we have put in and the impact we are making. But there's a huge resource that's sitting pretty much underutilized, and that's the private sector. What percentage of optometrists work in the public sector? It's currently less than 10%. How many audiologists work in the public sector as a percentage of what's out there? It's less than 10%. Less than 5% of oral practitioners work in the public sector. Dentists, dental technicians, and so on. So there's a whole lot of care that is available in the country, but not available to everybody. And somehow we've got to get all of this resource. 8,000 GPs are out there somewhere seeing a handful of patients. How do we get those people's resource back into the system to look after everybody? And that's what we are experimenting with in getting contracting units to work together. We need to harmonize the PHC benefits and the private sector benefits of what is at the moment. It's just a scrambled eggs. We do have a good primary healthcare package that we all know and understand in the public sector. But we need to harmonize that with what happens in the private sector. And you can only do it if you have a payment mechanism that allows you to do it. And one of the ways to do that is with the PMB review, the Prescribed Minimum Benefits Review. So while some are pushing to add really high esoteric things to the almost 300 conditions in the PMB, we are pushing to get a comprehensive PHC package as a PMB. And there are discussions going on, and whether it's a bolt-on or an add-on or an integrated or a what, PMB in the private sector during this transition period. And then the final point was, in terms of building on what we've got, is management. We spend 8.5% of our GDP on healthcare, and a huge proportion of that does not get anywhere near patient care or even healthcare intervention in any form. And it's because we don't have good managers everywhere in the system. And I'm not picking on the public sector here. I've seen horrific things in the private sector too. We really have to tighten up on how we manage our people, our resources, and when I talk about that, I mean money, but also all the other things that we use to look after the people's health in the country. Thank you.
Thank you. Thank you, Nick. That was nice and crisp, like your surname. Straight to the point. I have the pleasure and the honor of introducing Professor Lungiswa Nkonki, who is a lifelong close friend of mine, so quite pleasurable. I do not need to read her biography. Lungi started off as a research intern at Health Systems and worked her way up to becoming one of the country's earliest health economists, certainly Black health economists. She has extensive experience in actual research, which is not something that we find a lot in the academic sector now. You have people who've done quite a lot of reading and writing, but not people who've done research, who've gone, and walked through communities and done research. So she's a researcher, experienced researcher, a health economist. She was involved in the market inquiry. Please correct me if I haven't said the full name, which was quite incredible for all of us to witness. And she's now leading the health economics track at the University of Stellenbosch. Professor.
Good afternoon, colleagues. Thank you, Wanga, for... Yanga, sorry. Oh, dear. Thank you, Yanga, for such warm words and being so kind in your introduction. I do want to... Yanga mentioned that my journey started at Health Systems Trust as an intern, and I do want to acknowledge Tanya Doherty, who was my first mentor, from whom together in the consortium that we worked with Miki Chopra and David Sanders, learned how to integrate research with policy and advocacy. So thank you, Tanya. It's really a pleasure for me to be here today to give my views around the topic of universal health coverage. Universal health coverage is an important goal. It's as vital as it is challenging. And many countries globally have committed to this goal. And I do want to highlight that the countries have taken different paths because of varied contexts, level of resources that exists in those countries. But there are emerging trends from countries that have made significant progress towards universal coverage. And those countries tend to focus on primary health care, health workforce planning, and large investments in districts and sub-district infrastructure, as well as health financing mechanisms. So to me, the national health insurance, the journey to the establishment of the National Health Insurance Fund, now we have the NHI Act, is a means to universal health coverage. It's not in itself universal health coverage. And I'm going to limit my comments now to the private sector and reflect a bit on in particular, the supply side of the private sector, which is we framed in the private health market inquiry as facilities and health professionals. So in 2012, the Competition Commission observed consistent rising prices, and they were concerned that the private sector is not working as effectively as it should. And in summary, we found a largely unregulated supply side. And we found a large concentration of 3 big hospital groups, which were able to drive prices and increase prices year on year. And in addition to that, continue to invest on excess capacity. By that I mean building additional hospitals in areas where there's no justifiable clinical need, which drives utilization in a context of a fee-for-service environment that persists in the both in the facility side and also as a predominant reimbursement model in the health professional side. Within amongst health professionals, the first shocking thing for us was that we could not identify a reliable database of existing and practicing private health professionals. We had to do a number of different gymnastics to try and identify accurately who is practicing. So what this combination of factors it does is that it misaligned incentives. And we try to really apply ourselves in having identified what are the key misaligned incentives and what would be the appropriate remedies. Musa in the morning talked about that we need to build trust and that he was scared that we might, he said he doesn't want us to make mistakes. And I want to say to you this afternoon that we will make mistakes. For me, my hope is that we don't make avoidable mistakes. And going into the point of how do we use evidence. So this evidence from the health market inquiry was the country spent. I'm not going to say the Competition Commission because that is, to me, I view those funds as the public purse. 92 million rands to generate that comprehensive evidence that identifies what are the challenges within the private sector. And we applied our minds on how they could be remedied. The main thorny issue, because we identified that the supply side was largely unregulated, we made a recommendation of establishing a supply side regulator. Unfortunately, I think that there has been a misinterpretation of this recommendation. So what I see now, I think I would like us to separate. So we made a recommendation for the supply side regulator, and we had key functions that we had assigned to this supply side regulator. It's been 7 years, and it's quite clear that the supply side regulator has not been established and might not be. And the main rationale around that has been that we don't want to reinvest in the private sector. The purchasing, moving towards a single purchaser within, will allow us to drive costs within the private sector down. I want to caution against this, and not in a way, I mean, I was really battling sitting there and sitting here and thinking about the question that was asked in the morning about how do we use evidence? How do we use evidence that we have, and how do we use global evidence to inform our processes? So in the absence of the supply side regulator and the processes we have now in the planned committees, for me, the main thing is to identify clearly what are the key functions that were embedded in that supply side regulator, and would they be carried out in the formations that now we have outlined in the Act, and what we will see in the coming regulations. I think one final thing on the discussion around the formation of CAPs. One of the key findings of the inquiry was that in South Africa, largely general practitioners in the private sector work alone, whereas globally, there is overwhelming evidence in the move towards multidisciplinary teams. And part of what the reasons that are used for not forming multidisciplinary teams is around the regulations from the Health Professions Council on fee sharing, and sometimes funders within the private sector blocking the establishment of those multidisciplinary teams. So in conclusion, I want to say, even in the most mature single purchaser systems, which is in the United Kingdom, they have an independent monitor that supports the purchasing function of the NHS. If you allow me, Tamara, in one final point, I think this last point is not only the finding of the inquiries, the finding of any major study that has looked at the health system overall, is that there has been inadequate stewardship from the National Department of Health, to a certain extent from provinces as well, because the licenses issued to the private providers in areas that don't have a clinical need were issued by provinces. And part of the function of the supply side regulator was not only to work on the pricing, but to look at a rational planning need for the system as a whole. Thank you.
Thank you, Lungi, for also being short, even if you ran a little bit over time, but you were still quite concise. It is now my pleasure to introduce Umkhaya. Umkhaya is your homie, someone who comes from your area. Umkhaya because he, as a medical doctor, he completed his community service in the Eastern Cape, where I come from. So that makes him Umkhaya. So our next speaker is a medical doctor by training, but he's an activist. He's involved, actively involved in the civil society sector to reform healthcare. He's the Deputy Secretary of the People's Health Movement. I've already mentioned that he did his community service in rural Eastern Cape. But he's also a scholar, and I think that's an incredible combination to find and needed combination to find in an activist. So he's a Mandela Rhodes Scholar, and is also an alumnus of the South Africa-Washington International Program. He's been doing a lot of work coordinating the People's Vaccine Campaign, working as president for Shoko. He's extremely active still, as I said, in the civil society sector to ensure that the voices and the interests and the lived realities of the people who are targeted with these solutions or interventions is at the forefront. Welcome.
Thank you very much for that more impressive introduction than I think I deserve. I debated this morning when coming to the symposium which hat I would wear, whether the clinical hat or the civil society hat or just the health educator hat. I'm not a professor. I did not do a PhD with Prof. Schneider. But I am now in an email chain with her, so that's good. I'm also very cognizant of my personal identity here, that I'm presenting on behalf of, a huge grouping, civil society. And some of these ideas and stories are things I can't really present in a really true way, coming where I come from. So I'm going to start by paraphrasing and taking up Prof. Mashabeda's point around the need for defining concepts and why it's important. So to repeat again, the WHO definition of universal health coverage as when all people have access to the full range of quality health services they need, when and where they need them, without financial hardship, covering the full continuum of essential services from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. It goes on to say, though, that the delivery of these services requires healthcare workers with optimal skill mixes at all levels of the health system who are equitably distributed, adequately supported with access to quality products, and enjoying decent work conditions. And these definitions might be expanded to include measures of sufficient quality and of coverage, such as measures of catastrophic health spending. So we see when we talk about universal health coverage, we're essentially talking about universal access concerns, but it's the overlooked aspects of the definition that I want to talk about today, which are included, those of equity, quality, and the continuum of care. Universal health coverage, as it's often framed, is a financial protection mechanism, yet it forms part of a broader narrative, a broader whole within this older framework of something called primary health care, PHC, as envisioned by the Declaration of Alma Ata in 1978 and the long forgotten goal of health for all by 2000. And of course, the International Covenant of Economic and Social Rights. It's therefore a long beaten dead horse that universal health coverage as a terminology has shifted away from what it was at one point called universal health care. So if you look up the Wikipedia page, it's still called universal health care on the front page. I'm making a distinction here, and it's not a distinction without a difference. Numerous civil society groups, such as PHM, but not limited to us, have argued for a reframing of universal health coverage away from just its financial protection mechanisms towards a focus on PHC, primary health care, something distinct from primary level care that I'll discuss. The distinction I'm making is that a universal focus on coverage, whether public or private or insurance-based, to the exclusion of models that focus on forefronting decentralization, community ownership, and the social determinants of health and health promotion, will fail to deliver the very health outcomes we are hoping to tackle if our focus is not on those very health outcomes. So when you talk about health system strengthening or the national health insurance in most communities, as I have found, it is indistinguishable from a discussion around the social determinants of health and a strong public health system, strong primary level care service provision. It's indistinguishable from a conversation about housing, from a conversation about childcare or access to grants, from issues of transport and ambulance delays, roads, and food systems. Rooted in this concept of primary health care are the concepts of the social determinants of health and social solidarity. Even within a focus on universal health coverage, still as a financial model, we must not lose track of these broader aims of equity as intrinsic to the definition. But let's get to some of the practical questions that we were asked. What are some scalable and direct interventions that can be identified and expanded upon? Some of which are already legislated but not implemented, as the Giswa mentioned, that there are some recommendations that are evidence-based that we just haven't implemented. One often hears the narrative that UHC is a clear and admirable target, but that there are other mechanisms towards realizing health outcomes. But this is in the interest of the status quo that this dichotomy is presented. There's this false idea of two opposing sides. The naive idealist who is for the NHI and the rational cynic who is against it. Yet a recent analysis showed nearly 90% of respondents to the NHI bill at the Portfolio Committee on Health stated their agreement with the concept of universal health coverage, including those from the private health sector. And so we see that it's in the interests of those who want it to be depicted as equal sides debate that UHC is rejected. As an aside here, I'm sure Prof. Chris might attest to this, I now no longer know what the next sentence somebody is going to say is when they start the sentence with, "I'm all for UHC." The National Health Insurance presents a brilliant opportunity to bootstrap many of the WHO building blocks for health system strengthening on to our health system. Yet there are also low-hanging fruit that exist outside of this bootstrapping. For example, within the National Health Insurance, there will be the development of a national patient identification system, electronic record keeping, the development of standardized treatment protocols across public and private. And where these exist, there should be no contention around them. And many of these are not without stakeholder consensus. To the extent that these are taken up within the mandate of the National Health Insurance, it's something that there should be no debate around their validity. This morning, I took a look at the National Treasury's medium-term budget predictions for 2023-2024, which I think we all do on Tuesday mornings in rain. And on page 1, what screams out to you is that the South African healthcare system spends 7 times less on its direct primary level care allocations than it does on hospital systems allocations. It's on page 1 of the document. But primary level care remains a cost-efficient and an equity-forward approach. Section 27 did an analysis a few years ago of existing health reform proposals amongst all members of civil society and private sector, public health sector. And they found clear consensus around a large number of issues in the health system. 2 minutes here. If we are able to move away from this discussion of NHI as being for it or against it. Some quick suggestions, and they're too numerous to mention. One would be to implement the recommendations of the Health Market Inquiry, as Ngiswa spoke to. Step 2 would be enforcing a clear separation between political and operational spheres of health governance. It goes from MEC level down to CEO level and hospital board appointments. The third point would be the strengthening and capacitation of accountable hospital boards and clinic committees. It's a clear mandate within the National Health Act, but because it's left up to provinces, it's only paid lip service. And the very capacitation of management at this level, at district and sub-district level, should provide the model for learning how to structure CUPs, as we spoke to. 4, expansion of CHW scopes of practice, community health worker scopes of practice, with clear lines of management to deliver screening and health promotion into communities. And a 5th point is just the expansion of the authority of the Office of Health Standards Compliance to fill the gap that is currently being filled by groups such as Stop Stockouts and the Treatment Action Campaign and whistleblower clinicians. So these are some of the interventions that don't require a lot of money and just require some political will. It's like throwing darts at a dartboard. There's too many things that are easy to find. But I'll end by saying that on the day the NHA bill was signed into law, I was in Malitswai, former Aliwal North, with a group of Health Forum members from around the Central Eastern Cape, doing a health systems workshop. And I tell you that not one of the members gathered there had heard of the NHI. It's on the day the bill was signed. So they are the real experts, okay? They're the ones who make sure that there's enough diesel supply at the hospital, for the hospital generator, that when the roads are waterlogged, they have their potholes filled while waiting for the Department of Public Works, that family members with TB are brought into the hospital, and that old ladies with arthritis are given a bucky lift into the hospital so that they don't miss their appointment. So we learned this during the COVID pandemic, that there are clear failings in national health promotion and planning coordination. So we have to get practical about expanding health promotion, as talked about today, from a tick box education to direct capacitation of communities through linkages to resources such as the SAMRC. After all, research is advocacy. So there's so much capacity that we're not making use of, and it's not solely government's role. It falls clearly at our feet as civil society, and I think we're all included in that. It's messy, it's ugly, you might get rained on, but it's the definition of health for all. So thank you very much.
Thank you, James. That was excellent. Colleagues, at this point, I want to open the floor for questions regarding any of the presentations and inputs made by the first 3 speakers of this session. Do you have questions or comments for any one of them? Tracy?
Thanks. Nicholas, I was just wondering if you could maybe, 2 questions. One is to maybe reflect a little bit on what James was saying about universal health coverage versus universal health care and what are your thoughts on that, and what does the department say, and is there a distinction? And then also, like, I know that this is not as simple as, and I mean, I've heard you speak on many different occasions, but in what you were saying, it sounded like you were saying, if we throw more money at it, like that's going to make it better, and I know that's not what you're saying. So I just wondered if you can comment a little bit on the throwing more money at it, and that makes it better. Thanks.
Yes.
Sorry, so did I say you're going to throw more money at it? No. Yes, there's 8.5%. We only need 7.5% of our GDP to do better work than we're doing now. There's more than enough evidence of that. If we were not having so much corruption and misspending because of bad management in the public sector, there'd be more money to do more healthcare. If we were not spending more than half of the private sector money on totally unnecessary, no value add, we would have another 150 billion rand. If we were not paying principal officers of medical aids 9 million rand a year to look after 500,000 lives, and then they still outsource to a private company that is making a profit, we would have that money for healthcare. If we started using GPs as part of the interdisciplinary care or multidisciplinary teams together with the public sector, we would have clinical governance from qualified medical practitioners. Those were the points that I was making. So, we definitely do not need to be spending 8.5% of our GDP. The administrative costs in the average single-payer system around the world is 2.5%. We are spending 9%. How can we justify that? Because of the administration. So there are lots of problems. While I've got the mic, also to talk about the part of the HMI around the supply-side regulator. Part of the reason it couldn't be implemented is because there's a statutory lacuna that makes it impossible to implement it. And now we have a judgment that makes it impossible. Every single license issued for every single hospital since 2003 is illegal. Because sections 36 to 40, which is used to issue those licenses, has never been part of the law, and now it's been outlawed as unconstitutional. So the only licenses are those who are issued in terms of Section 44 of Health Act of 1977, which made it a national function with a national regulator, which was all undone during this process. So these are complex, interrelated difficulties in implementing things. The OMRO that is recommended in the health market inquiry is already a function of the Office of Health Standards Compliance. So why do you want to set up another agency to do something? Treasury won't even give us money to strengthen the Office of Health Standards Compliance. How are they going to give more money for an OMRO? They're not going to. So there are constant limitations in all of these dynamics. I definitely am not suggesting we need more money. We don't. We need to manage what we got a lot better than we do now.
Thank you. Thank you, Nick. I think because of time, we won't allow more questions at this point, but be encouraged. When we are done with all of our speakers, we will open up the floor for more conversation. Thank you.
Very well said. So thanks. I'd like to welcome Jeremy, who I think introduced yourself briefly this morning, but Jeremy Grimshaw is a friend and colleague, a family physician prior to doing his PhD, and then a leader in implementation science, knowledge translation, health services research. And speaking a lot, you've been teaching us a lot about incremental, small trials that try and improve things slowly and incrementally. So I'm looking forward to...
Thank you. And thanks again for the opportunity to participate today. I don't have any great wisdom that's going to, I think, dramatically help your journey. You have great wisdom in the country. But what I can do is reflect on my perspectives from a Canadian perspective and also from a global perspective. I come from Canada, and many people think we have, the US thinks we have socialist medicine, that we have universal health coverage. We don't. In Canada, the Canada Health Act states that all essential services will be free at the point of care. But when it was implemented, they defined essential services as hospital-based care. So primary care was cut out of that. Now, most provinces will actually pay for the primary care consultations, but things like drugs prescribed in primary care, tests prescribed in primary care are not necessarily covered for that. And it really is heartbreaking because this again impacts on often the most vulnerable or poor people in our community. I have work insurance. That's great. Many Canadians do. But it actually really has a very deep impact that doesn't make me proud as a Canadian. And we're trying to do something about it. We're currently undergoing two major transformations. At the national level, we've established the Canadian Drug Agency. And this was originally going to be creating national pharmacare, which again sounds very similar to what you're trying to do here. As it's got implemented, it's basically got watered down. So in the first wave, there now is a suggestion that contraceptives and diabetes medicines will be made free to anybody, but no other drugs. Now, it's great that we're getting contraceptives and diabetes medicine, but there are many, many other things we should be providing. In my province, we're trying to develop local healthcare networks to provide population-based healthcare. It sounds like it sounds like we're in a worse position where we have a very hospital-dominated sector, and there's really very poor links between the hospital and the primary care sector. The moment in my province, something like 20% of patients, citizens, do not have access to a family doctor. As someone who trains the family doctor, that is striking. That is something that just eats away at my core. So this sounds familiar, and in fact, it sounds like we might be worse off or start in many ways to you. So hopefully that just sort of reassures you that, hey, there's other places where they're much worse off than we are. One of the things when I think about these transformations, I think there's kind of three levels of activity. One is we need to think about the policy formulation, getting the policy right. What are the sort of issues in that legal framework and regulatory framework which will allow you to enact what you need to do? But then the second, and I think Nicholas has referred to this either in his comments earlier or maybe over lunch, is actually the population planning about, well, okay, how can we actually do this stuff? What do we have to do which might lead to redistribution of resources and other things? And then the third is on-the-ground implementation. And when we think about those three levels, if we're going to be successful, we need to be acting at all of those three levels. And I would argue also trying to make sure at all those three levels we're using evidence to inform our activities as we move forward. One of the things that I've been involved with during the pandemic and after is when the pandemic struck, we saw a huge amount of noise being created, a lot of duplication of effort in terms of people doing lots and lots of reviews, answering the same question, and really a very uncoordinated and not particularly helpful for decision-making process. And we created something with John Lavis, who's my dear colleague at McMaster University, who probably should be here because he'd give you a much more informed contribution, called COVIDend, which was trying to bring together, we had about 70 different groups from around the world. We had a lot from Africa, in South Africa, Uganda, Cameroon, probably Nigeria, probably other countries that I'm missing. But largely sort of saying, how can we as a global community come together to try and work together cooperatively and collaboratively and reduce inappropriate duplication. What we learned during COVID is there's a lot of innovations about how we rapidly can synthesize evidence for the needs of decision makers. My colleague John has actually got a sort of a 2-day service, 2-week service, 3-month, 6-month service. That you could actually fairly rapidly turn on. Within Canada, we've created what we call a general contractor process, where basically working with the Public Health Agency of Canada, they would give us their questions, and we would sort of say, oh, there's a group in Alberta that could do that. There's a group over here that could do that, to really try and make sure that actually we were working together in a concert. Following on from the COVIDend experience, we created something called the Global Commission for Evidence to Address Societal Challenges. And what we're trying to do there is to reimagine the evidence world and how it can serve the needs of all better. And if you're interested, if you Google Global Evidence Commission, you'll find the website there. We had 24 commissioners from around the world. Quite a number from Africa, I can't remember off the top of my head, but we came up with 24 different recommendations that had actions at different levels. we're working on three major priorities. Two of whom, well, probably all three are relevant here, but one is sort of thinking about how we can strengthen national evidence support systems. In many countries, there's a research system, there's an innovation system, but there's not really very much which is actually sort of saying, how do decision makers at whatever level access the best evidence? How do we support them to do that? We are undergoing a study across 12 different countries, and in South Africa, Lawrence Langer and Tanya Midlozi from the Pan-African Collection for Evidence is looking at the South African experience, probably not in the health sector. And it may be, as you're moving forward, some of the tools that we're using might be helpful to say, how can we easily and quickly sort of try and up our game on this? The other thing is that I think there's this real opportunity to think about how you can lever global evidence. You're not the only country trying to do this. Canada's trying to do that, but there are, I don't know, probably 150 countries trying to do something in this space. How can we work together to learn as we go and to synthesize evidence that will be helpful? That would need to be contextualized locally, but you have the local context experts who can think about that. Often in this case, I think the role of evidence is enlightenment. It's helping people to think smarter. It's not that you're going to find a process, if we just do that, it'll be fine, but you'll learn, well, they tried it there, it didn't work very well, but it might work here because of this, or, actually, no one seems to have done this yet, we should do that. And globally, we are moving to sort of try and develop a much more coordinated global evidence ecosystem, which is very much built on things like living syntheses of evidence. And by that, I'm not just sort of talking about quantitative evidence, I'm talking about evidence about any type of question, because this is not something you're going to solve in 3 years, 5 years, 10 years. This will be on the agenda for the lifetimes of people in this room, and probably their children beyond that. And so again, why don't we start as a global community to think about how can we sort of work together to actually sort of fully access this? There are examples of that. The SDG evidence synthesis, for the first time, UNDP has actually produced a global college to try and provide syntheses relevant to the social determinants of the SDGs, thank you, the Sustainable Development Goals. But that's an example where we can come together globally to try and work. It will hopefully reduce that. I think it was Ngazwi who said, we'd like to avoid the obvious mistakes. I completely agree. I mean, each country will learn as they go, but if we can use that global knowledge and understanding and then thoughtfully think about what does it mean for us here, then hopefully we'll be in a better situation. So that was what I just wanted to say. As again, I'm learning a lot, and in Canada, we'll watch what you're doing here because I think we've got a lot to learn from you, so thank you.
Helen, please come up. So I think everyone has been introduced to Helen. Supervisor extraordinaire. Everyone, I mean, so thanks very much, Helen. Public health specialist, Saatchi Chair in Health Systems Governance, and we're very happy to have you here. Over to you.
Thanks very much, and thanks for bringing us together. It's a wonderful gathering. So the title of this session's got an important word there, which is now, and the other one, which I think is significant. So what do we need to do now? And then challenges and targets for quality healthcare. So I'm going to, at the risk of repeating, I think, what is being said over and over, but I think that's quite useful because I think we're starting to see some major themes emerging. I'm going to say what I think in answer to the 4 questions posed to us as panelists. I'm a health policy and systems researcher. I've worked largely around thinking about the public health system in this country. And there's actually a presentation. My presentation's come up. That's nice. I wasn't expecting that at all. Thanks, Tamara. How do I move this? Yeah. All right. So I'm a health policy and systems researcher. I've worked on district health system strengthening. I'm interested in questions of governance, but particularly local governance, but take quite a multi-level perspective on governance. So I am going to be talking from that perspective. So those are my top 3 challenges. We cannot repeat enough the social context of being probably the most unequal society in the world in wealth and income. And we need to be constantly mindful of all the implications of that. So it's mirrored in this extreme inequity between public and private sectors, which is the fundamental structural problem of the health system in this country, I think we all recognize. And in fact, that structural inequality reinforces the broader inequalities of the society. But through a variety of pathways and mechanisms, material, social, actually have produced a fairly catastrophic disease burden in this country, and we need to recognize that. And that figure here is work done by the MRC on what's called amenable mortality a few years ago. The burden of disease unit compared amenable mortality, which is a combination of treatable and avoidable, preventable mortality in South Africa, and found that our amenable mortality is 4 times that of Chile. So we may have treated ourselves out, more or less, out of an HIV epidemic. We're not going to be doing it with NCDs and other conditions. The prevention challenge is absolutely imperative, and we need to grapple with it in thinking about policy, in research, in programs. The second challenge, and that comes from my immersion now in a number of different public sector realities in this country, across many of the provinces, actually, is this intense politicization of our public sector, our public health system. And what is meant by that is that political executives, elected officials, MECs, and other players become involved in the routine bureaucratic operations of the system, and with the resulting risk that those operations serve political interests, often factional political interests, and producing the problem of corruption and fraud that was highlighted as a key challenge this morning. It's a deep-seated problem, and one that we have to grapple with quite head-on. And if one thinks about an absolute current challenge in the health system at the moment, literally in the last year or so, is dramatic budget cuts, austerity measures, and the freezing effect that has on health systems, and the limited fiscal space, in fact, for innovation and creativity. So those are my 3 top challenges. Can you help me with this? Oh, yeah. Okay, so what do I think are some potential system-wide reforms? I'll tell you, yeah. And interventions both within and outside of the health sector, again, thinking questions of scale. And I've highlighted there an idea, legislative reforms that separate the political from the administrative. So we know that at the moment, and it's not spoken about much in our circles, actually, in the health system, we haven't really discussed what's happening in the wider public administrative space in South Africa. But this is, in a sense, some kind of movement in the post-state capture era. There's a series of legislative and institutional reform proposals out there which seek to separate the political and the administrative, which limit the power, for example, of MECs over the appointment of health personnel in provincial bureaucracies. The Public Service Amendment Bill was passed by the National Assembly last year. It's sitting at the NCOP, and we should all be clamoring, actually, for this legislation to be finalized and implemented. There's the National Framework for the Professionalization of the Public Sector. Secondly, to strengthen the fundamental unit of the health system, call it CAPS, call it what you like. Absolutely, that's what we should be focusing on. UHC places primary healthcare at the center of its thinking. In fact, I think we need to think primary healthcare plus, not only towards social determinants, but seeing primary healthcare in relation, locating primary healthcare more clearly within a local health system that includes, for example, a district hospital, community-based services, that thinks about the local governance arrangements, particularly at the sub-district level, and that focuses quite heavily on their collaborative functioning. And that, if you see that diagram at the bottom right, is a model developed in collaborative work with some of the players in the Health System Research Unit on what it means to steward a local health system for quality and outcomes. And we identified 3 key factors: leadership capacity, which Nick has also alluded to, the ability to coordinate activities in geographical spaces, collaborative functions, supportive district systems, as that kind of combination of factors as being quite key to improving quality and outcomes. And then thirdly, action on the social determinants. And we need to get quite concrete, I think, on these kinds of issues. But the ability to coordinate sectors locally, the local governance mechanisms that bring actors together. There are a lot of experiments across the country. We need to evaluate them. We need to, control consumption of sugar, tobacco, and alcohol, for sure, all the legislative and tax measures. And I think there's a particular need to think about what's happening in early childhood and the nurturing care framework. And my time is up. I see the pink thing is waving at me. So I just want to reiterate what several people have said, because I think in thinking about what how we reform the system, we should not break what currently works, okay? We have a primary healthcare system in this country that's received a lot of investment in real terms. That diagram with the orange bars on the right shows real increases in spending on primary healthcare, and primary healthcare is a percentage of total expenditure. That accounts for what you see on the left, the fact that South Africa has very low out-of-pocket payments. And in fact, the whole drive for UHC globally has been to limit out-of-pocket payments. We already provide universal health coverage. We have limited out-of-pocket payments. Primary healthcare is free at the point of use. It's in fact an important system. How do we build on it? And maybe I'll stop there. We can talk about knowledge needs. Yeah.
Thank you, Helen. I would love to hear so much more from everyone, and I'm sorry to be the one with the pink flag. But you're very happy to have Reno here. Thank you for coming
very much.
through. Also public health medicine specialist, but now kind of chief operating officer. You were at UCT, and now kind of leading programs and implementing care. So yeah, I think it was the programmatic implementation view that we're looking forward to hearing more about. Thank you.
Thank you. Thanks for the invitation. I somehow feel that I'm between Amandla and Cry Our Beloved Country whenever I speak here. The other thing is, Helen referred to now. South Africans have an expression, now. And my now with the reforms around UHC and progressing is that we would take about, and you can call me back in due course, about 10 years to put in the building blocks. That's my view. 5 years after that, we'll shake the system and stabilize it. I will be 75 in 15 years' time, and I'll run down the stairs if you invite me to the panel then. So please do. So I want to focus on the top 3 things that I think we need to do to progress to UHC. Agree entirely with Helen, we need to separate the political and executive decision-making. Agree entirely with Nicholas, addressing corruption. My own view is that we must address corruption when public funds are used. In my opinion, medical aid scheme funds are public funds. So we must take that perspective. It doesn't matter what the funding source is, they are public funds, and we must speak boldly about medical aid fraud as we do about the tragedies of corruption within government. Thirdly, failure to address reforms, and in particular, there are a number of reforms. I agree with the Health Market Inquiry report. Simplistically, right regulation is a success of government, wrong regulation and failure of regulation is a failure of government. With regard to system-wide interventions, I want to focus on 2 broad areas. The information platform for UHC, that's Section 40 of the NHI Act. 2 important things. We need a complete health electronic record to improve patient management, public and private sectors. The second thing, we need, and I have the privilege of sitting on 3 regulators, an integrated platform and architecture that provides interoperability and the sharing of data and the management of that information. I sat on the Council of Medical Schemes I implemented when the first act was implemented in 1999. I've sat on the Health Professions Council. I'm deputy chair of the Office for Health Standards Compliance. None meet data. The data is completely separate. We can't even plan properly because these regulators' data don't speak to each other, let alone the data that's in the public and private sectors. We are not going to get there if we don't do that in terms of information platforms. The second component I want to focus on is Section 37 of the NHI Act, and that deals with contracting units for primary health care. 2 matters I think that we can do. One is we must develop that service benefit framework that details the healthcare benefits to be purchased. And secondly, we must get on with developing reimbursement models, including the capitation provider payment mechanism, and Nicholas referred to that. On the third question, how to advance evidence-based or evidence-informed policy process. I have sang this song for the last 15 years. I have failed dismally, but I will sing it again. An upfront agreement, non-negotiable. Output of all policy and technical work must be placed in the public domain. When you have reforms that are going to go 15, 20, 25 years, we cannot have secrets. It's just not doable. And I will appeal to everybody in the room, make sure that data and information gets into the public domain, non-negotiable. The other, agreements for the first port of call for commissioned work. I'm of the view that open calls are most welcome. But when we commission work, it must involve private and public countries in our own country. Commissioned work needs to be led by South African institutions and entities, and we choose who we partner in the international domain and which agencies, not the other way around. Thirdly, Nicholas, establish those NHI implementation committees. We need to have those committees established with membership that is multi-stakeholder. Choose the people that fight with you and put them in the committees. Dialogue is healthy, reform is long, collaboration needs to be maximum. So we want to have multi-stakeholder committees with predominantly South African experts, and we invite international experts as we deem fit for the issues that we need to deal with. The 3 are in the Act: the Benefits Advisory Committee, the Healthcare Pricing Committee, the Stakeholder Advisory Committee. Please, Nicholas, publish those and call us to serve on them. We South Africans, we must serve our country. Lastly, what are the potential strengths to advance UHC? I have been impressed over the last 15 to 20 years about the intellectual capital that exists in our country in both private and public sectors. Secondly, we do have strong and weak health system and health service delivery experience in both private and public sectors. In my humble opinion, we are not using that experience to the benefit of our nation. Thirdly, past and current policy and technical reports, those that are in the private domain, get them into the public domain, and they must serve as dialogue and critique and good analysis. Fourthly, we have high capability and capacity in our South African institutions and entities to conduct research and technical work. And lastly, we have the capacity and capability to plan and implement important pilot projects. Let's get our act together. While I don't like Nike as an institution, I do like that tick. Let's do it. Thank you very much.
About 15 minutes. Yeah. Thank you, colleagues. Thank you to the panel members. What rich contribution you've made. Tamara and I had wondered if you would be able to talk to each other in the way that you present your thoughts on the topic of universal healthcare, and you did. And so I want to open up the floor to first have a conversation for people to ask questions. But first, I just want to point out the themes that have emerged because the panel members actually talk to each other. And it is, I think it was Helen who pointed out that it is actually a strength. It's positive that there are so many commonalities in the different presentations. So my take home for me is that to address the challenge of poor universal health care in South Africa, we need to, one, strengthen and center primary health care. And Helen's innovation was primary health care plus. And that secondly, what all the panel members agree on is the need for legislative reforms. That when you do not have the legislation that you need to be able to regulate the private sector, you get the avoidable mistakes that Lungi talked about. But additionally, as Helen pointed out, you open up all kinds of opportunities for corruption. And thirdly, that we need to use the evidence that we have and generate the evidence that we don't. And I think Jeremy spoke a lot about how we should be thinking about that evidence that we don't have. That Kwais Lungi talked and said 92 million rand was spent to generate evidence, but it's not being used. But Jeremy is saying there's evidence existing in the global sphere. There are collaborations taking from our learnings in terms of how we came together during COVID, that you could have these global evidence ecosystems that you establish that countries such as South Africa can then learn from. So on that note, colleagues, I invite you to share your thoughts, your questions, your comments from these 6 presentations that we've had. Thank you. Yes, and if there are any reflections that you want to share as well as the panel. We don't have a lot of time. I think we have 15 minutes. Maybe we have less now because Yanga spoke a bit more longer than she should have.
Good afternoon.
We have 15. We still have 15.
Good afternoon. I'm Benjamin Mohoje. I'm coming from the National Health Laboratory Service. I'm all for UHC. There's no but. I also support the National Health Insurance. My but, coming from the pathology sector though, is that, on the NHI Act, it's quite mute when it comes to pathology services. There's not much about pathology services. And my question to Prof. Crisp is with regard to funding for pathology, because on the NHI white paper, it was talking extensively about the need to move away from the fee-for-service to some sort of a reimbursement, alternative reimbursement like capitation. On the act is not explicit, and I just want to find out what is the thinking on pathology when it comes to funding. And the other question is on mechanisms for accreditation. Maybe Dr. Mora can assist, because also there, it doesn't really say much. I think a lot of accreditation, it's as if, in a way, when we're talking about OHSC, it's more pointed towards clinical, but for the laboratories, what is the thinking? Or maybe the question would be, how will OHSC collaborate with SANAS in respect to accreditation? Thank you.
Okay, thanks very much. So how do I explain what's in the NHI and how capitation works and how DRGs work? The price of pathology tests, radiology tests, medicines is all in there. So when you pay for capitation, you pay for a package and you transfer the risk to the provider to get ideally to get an outcome. So the choice at the moment is what goes in the package. In other words, what's feasible, what can you expect the multidisciplinary team to provide? Then you have to make sure that the population that multidisciplinary team serves is big enough to make it a viable, if you like, business or opportunity for the practitioners in that space. And then you have to decide what is included in that payment mechanism. So point of care testing might be included, but lab tests that the practitioner can't control and that you don't want them to underservice needs to be paid for in a different mechanism. So that doesn't need to be in the act. Same in a hospital. When you pay for a DRG, you're paying for the whole DRG. You're paying for the outcome. That's the structure of the DRG. And the lab tests and the radiology tests and so on are part of that standard algorithm of what is in that diagnosis-related group payment. There are provisions for case mix and all other ways of structuring those payments. And there's also mechanisms provided for in the Act for global payments. The details of those change. And over time, you want to give space for the evolution of technologies and so forth. So you put that in regulations. The regulations for those details are going to be quite a long time in coming. We are busy with the regulations on governance to answer Reno's question. We have outsourced that to a legal firm that does legal drafting because we want absolutely transparent governance that you cannot get political interference or that you reduce it as much as possible. So that is about 3 weeks away, and then we'll publish it in the Gazette for public comment. So you should start seeing the proclamation of the first clauses of the National Health Act, at least sections 12 to 30, in about a month from now. So after that, once you've got a functional entity and a board appointed and so forth, then all these other things start to happen. But there are already, there's a lot of work being done on what's in this initial package. You have to start small because it's got to be funded, and there's a shift of funding that has to happen. The electronic medical record is being field tested at the moment, so we've through quite a range of that. And the reimbursement models for primary health care is actually quite well documented. It'll go out for consultation as soon as we have got the governance regulations out. So yeah, we're getting there.
Sorry, I didn't say. I just wanted to speak about the accreditation issue. I have said it before I got onto the OHSC, and I've said it in the OHSC. In my opinion, the current regulations and accreditation of facilities and hospitals, the link between the criteria and quality healthcare is at least 10 years. And I feel that that is where our greatest work needs to be. Because when you accredited facilities, you're not accrediting it from a control and compliance point of view. You are accrediting facilities in order to deliver quality health care. And the current accreditation process doesn't do that. And in fact, the OHSC working with the Department of Health, are re-looking at that, because you could have 10 criteria that give you a better sense of what quality is happening than have the 500 and not know what's going on. Yeah.
afternoon, Percy Downs, Council for Medical Schemes. Three of the speakers mentioned the CUPS, and I mean, there's every reliance on CUPS being implemented correctly for us to actually achieve some form of universal health coverage. But very little detail is given about the CUPS. South Africa has very good policies, but we have implementation paralysis. Okay. So with the CUPS, do you foresee to be a more not-for-profit entity, or do you see it being incorporated into the private sector? Because those are the decisions that actually can determine the successful implementation of that. Because as we move to primary healthcare, you used to say, probably a social economy or not-for-profit entity will be much better because all the surpluses will be put back into the healthcare system to provide extra additional services as we move along. But as soon as you're going to have private sector contracting again, we'll see that going into shareholders in the country, and we're having world-class primary healthcare centers, but the outcomes are not as good. It's similar as to the hospitals.
Yeah, so the contracting unit for primary healthcare is a geographical space for funding allocations. And the funding allocations, according to a capitation mechanism, is per capita. So if you've got 150,000 people in a designated contracting unit for primary healthcare, you allocate using the same formula to that 150,000 and the next and the next and the next. The providers within that space have to use that money to provide the same set of benefits with the same challenges for outcomes. It might be slightly different because one community might have a higher hypertension and diabetes than another one might go for HIV and so on, but they get set targets. So the first thing is that every head is equal, except when you weight it for whatever risk factors we decide to put in the formula. And we will weight originally in the first phase for age and sex, because we know that that's where the predominant differences are in the primary healthcare space. But once we have coherent data across the whole system, we can start to add epidemiological factors as well to the weighting. But that's it. So the provider space, there are 9 CUPs under testing at the moment, and they are proof of concept. They're not just pilot things, they're actually the rollout. So Ditlabeng in the Free State is the one that's the furthest down the line, and that's where the information system is at its most mature, and that's where the electronic medical records are already implemented. They've got a local steering committee, they've got a provincial steering committee, we have a national steering committee. It includes rehabilitation, nursing, doctors, public sector, private sector, everybody in these various steering committees to try and understand what is it that will make it scalable. So the intention is, if you read the financing mechanisms of the Act, is that what we currently spend on personal health care in primary health care will be channeled into the fund to pay for those services through this capitation mechanism. It'll be a long way to go still. And once we've understood these, the differences between the rural and urban, the high dense populations, the very rural populations, lots of private, no private, and so on, then we will have these sort of, if you like, sentinel sites that we can use that information to roll out on a wider scale. So you're welcome to contact me afterwards. We'll put you in touch with where these centers are. There's one in every province, and they are quite different in their approaches to things. Yeah, thanks.
Do we have any more questions? I'll take one question, if there is one, or comment. If there isn't, oh, okay. Then after that, I will invite the panelists to share any reflections that you might have.
Helen, I was just wondering, in the your three responses, is that where do you think a national public health institute will fit? And because NAPISA has been spoken about for, I don't know, 10, 15 years, and would that not be a way of certainly countering the, sort of separating the political sort of creep that comes into the appointment and running of the health services?
We were sort of given a rule of threes, I think, on this panel. So we had lots of things we would have said. And NAPISA, yeah, and I think NAPISA speaks to what Reno is talking about, of triangulating different sources of information and bringing a public health perspective. I think it would bring a kind of more of an outcome orientation, perhaps to thinking about services. But yeah, the Nampisa Act was passed a while ago. Another example of legislation that what's happened to it. Yeah, I agree. And I think it's important for the social determinants of health as well. Yeah.
Yeah, so Napisa is back on the agenda now that Minister Motsoaledi is back. But essentially the problem was that the Treasury says there's no money for anything new. So can't implement it. We'll find a way around it, I'm sure.
Okay, dear panel members, do you have any reflections, any responses to each other's presentations, any final thoughts? Anything that you couldn't fit in those 3-4 questions that you are absolutely burning to share? Okay, so Lungi first and then
Hello. I only had to say I'm really excited. I want to watch what happens here. I think there is huge potential and it would be wonderful. So congratulations to everyone here.
Okay. Okay, great. I think I really want to congratulate Tamara and the MRC for organizing this dialogue. My final reflections are to really agree with Helen on that we really do need to separate legislative, to have legislative reforms that separate the political from the administrative. So I think my colleague here has said, everyone says we're all for UHC. I think we are all for UHC, but we cannot ignore, and we would like to keep an open mind and a constructive engagement. But we cannot ignore the lessons that we've had. So for instance, I do think that when we talk about this essential benefit package that we are waiting for, it's quite key what the sequencing is of our implementation. In the Act currently now, it says the first step is to establish the board, which I think is important. But it is important to be clear on what the benefit package is. And we must remember that the current benefit package that we have in the private sector that has lasted for 24 years, which was meant to be reviewed every 2 years, is another example of inadequate stewardship. And so when we thought about the supply side regulator, I don't want to belabor the point, is we were mindful, we tried to really think about how do we plan or assist the state to really have a chance at really dealing with this inequality problem that exists within our system and unifying our system. So we didn't ask for more money to establish OMRO. We had recommended that private sector resources that exist in the meantime are used to incrementally establish a system of reporting outcomes, of developing the PCN numbers to have the information system that Rino was talking about. So I really do think that when we have the view, when we look at the recommendations of the inquiry, we mustn't view them as the recommendation was we need additional money to establish new additional institutions, but rather what were the sequencing and what were the key actions that were needed in the meantime as we walk the journey for the next 10 years, for the next 5 years, for the next 20 years. Thanks.
But we have run out of time because there are colleagues who have to leave. But thank you so much. This was so excellent. I'm sure that we're going to have continue having conversations with each other. For those who stay for dinner later on, my head is absolutely buzzing. I think it's just been such an incredibly fruitful, incredible conversation that we've had. Thank you.